Good morning and welcome from Mount Sinai, New York City, from the Division of Endovascular Division here for a monthly live broadcast. A very happy new year to you. I'm your moderator, Vishal Kapoor, and I'm joined with my partner, Karthik Guja. And today we have a special moderator, our good friend, Dr. Atul Kukar, who will be joining us as well. He's the Chief of Cardiovascular Services at Mount Sinai, Queens, and also the Assistant Director of the Peripheral Endovascular Program here at Mount Sinai. So without further ado, good morning, PK. Good morning, Raman. Happy New Year to all, and let's dive into the case.
Yeah, we have a good morning, everyone, and welcome to the lab. We have a really exciting case, and it's a new year, 2022. Very successful year in 2021 for our program, as well as a very difficult year for all of us with COVID. So hopefully much more brighter and happier year in 2022 for all of us is what we're praying. So welcome, and we have a really good case to kick us off with. Again, to my right is Dr. Raman Sharma, who's our newest attending here at Mount Sinai, and one of our assistant directors of our program here, doing a great job. Behind me is Ray Lascano, as all of you know, has been with us for every single live case that we've probably done. And then in front of Raman is Twinkle Singh, our outstanding endovascular fellow this year. And behind us is Elizabeth Holton, our nurse, and Damian Cabrera, as always, supporting us with all the work. We've got a really fantastic case for you, and a very difficult case. You know, we struggled finding a case because of COVID. We really, I think as a team, we looked hard and we found a really good case that has a lot of teaching points. So before I start elaborating those and getting everybody's opinion, I just want to have Twinkle go ahead and present the case.
Okay. Hello, good morning, everybody. Hold on just.
I think we're having some technical issues. Somebody go to the next slide for her, please. So this way.
Next slide.
Next slide, just in case, because the remote is not working for whatever reason. Oops. Yeah. Go back again to the slides. There you go.
All right, thank you. So our case today is about 63-year-old male with previous history of peripheral arterial disease, has had 2 failed vascular bypass in the left lower extremity, and now is presenting with a known healing left toe ulcer, and that started about 4 weeks ago. His past medical history is significant for hypertension, hyperlipidemia, atrial fibrillation. He's a heavy smoker and ischemic cardiomyopathy with 30% EF, CAD with multiple prior PCIs. He is currently on aspirin, Lipitor, Losartan, Toprol, Amiodarone, Torsemide, and Eliquis for A-fib. His pertinent labs significant for hemoglobin 13.7, creatinine is 1.0, LDL is 44, INR 1. Next slide. Okay. So here we have the diagnostic angiogram from last time. On the left side, as you can see, the SFA has a blunt stump proximally, and it reconstitutes from the collaterals from profunda at distal pop level. And it's much more well visualized, the reconstitution on the image on the left side. Next slide. So again, below the knee, there's a good 2 or if not 3 vessel runoff. And we can show more pictures on our diagnostic angiogram that we did here.
So I mean, it's actually referred to us by one of our very close vascular surgery colleagues in our local area. So he's had 2 bypass grafts. Both the bypass grafts were vein grafts that they had placed. Now, in all fairness to our surgical colleagues, you know, a lot of these patencies of these grafts are also dependent on the patient and how. Can you hear me? Okay, and
yeah,
how,
we can hear you.
And how compliant the patient is. So the patient, you know, obviously has had multiple admissions for CHF since the surgery, multiple hypotensive episodes, and had stopped anticoagulation a couple of times. So therefore, you know, I think the bypass graft going down twice has a lot to do with his comorbidities, and also with the fact that you know, he is just not a good how can you say a protoplasm for these bypass grafts to work. So having had multiple admissions for CHF, even though he has such a robust runoff, our vascular surgery colleague felt that we should try something percutaneous, since percutaneous has never been attempted on this gentleman. So when you look at this particular lesion, as Twinkle showed, now we're just showing you the ostomy of the SFA. We just have a wire in just to honestly, just to get the catheter down, we just had to get a wire into the SFA, and it's a glide wire at the level of just at the level of the cap. You can see the profunda is robust coming all the way down. Scene minus, Twinkle, or scene plus. I'm sorry. And then you can see here that oops, it's plus, yeah. And you can see at the level of the popliteal next. At the level of the popliteal, there's absolutely no collateralization and no visualized or named vessel that we can really look at. Below the knee, Raman and I were noticing that you can start to see a trifurcation form, and you can see that the popliteal is there. And then, as you saw with Twinkle slides, you have the posterior tibial, and I think we did a fluorosave just to reduce the contrast. On the next picture, maybe we didn't, but you saw that what he had below the knee, you clearly saw that he had a very robust posterior tibial. So a couple of interesting points Raman and I were discussing that I think you have for the audience at home. Scene minus 2. Yeah, this one. So it's important when you do a selective SFA shot like this, you see this collateral coming off the SFA. So one of the questions you have to have is this collateral the one supplying the distal vessel, or is there a profunda collateral that's also as robust? So what Raman and I did was kept the catheter at this level, and we shot again next. And you can see at this level here, you can see that the anterior tibial. Can you 1 second, please? The anterior tibial does fill, but very, very, very slowly. You can see right there at the end. You can see the anterior tibial, or maybe the next one, right? Yeah, the next one probably. The next one. Yep. Yeah, this is the one. You can see here that the anterior tibial is filling very, very, very slowly. Right there. This is from the profunda. This is from the profunda. So the majority of the anterior tibial collaterals are from the profunda. So which of course you don't want to knock off any collateral, SFA to distal popliteal collateral, but I mean in likelihood you're going to. So having said this, I just want to turn it over to you guys and let me know what your thoughts are, and then we'll go over what our plan is to be able to cross this lesion.
All right, great. Atul, let's start with you. What's your strategy? What do you think is the best case scenario in this case?
First, Happy New Year. This is a great case to start the new year with because it's quite challenging. I think in this case, that coming antegrade alone is going to leave you, I think, in some no man's land where you're not sure where to go. So I would start this case with a pedal axis as well as antegrade, of course. And I would go with that approach. I think it's gonna be hard to track down through the long SFA into the pop and then direct into the the anterior tibial or the perineal or whatever the TP trunk, whatever you're seeing there is. I think if you have a good runoff at the ankle, you come up from the ankle first and try to get somewhere yourself into the SFA and then try to connect in the mid SFA.
Karthik, what about you? What's your approach?
I would give it a shot. I think there is a
I think we can't hear you.
Fix his mic.
So Vishal, what would you do?
Yeah, so I think you're right. I mean, my approach will be both ways. I mean, we have a catheter placed proximally going up and over, and we have, of course, distal visualization of the ATA. So I'll definitely try to give one shot going down. I know it's a long SFA CTO and it's pretty much reconstituting at the distal pop, but if you look, I think we'll fluoro to see the degree of calcification is not as much. And we know, remember, calcium is your friend as well as your enemy at the same time. Friend being you can see the mark of where you're actually tracking, enemy meaning that it's just going to deflect you off. So in this case, I don't think there's enough high-grade calcification to really make things bad for you. But again, you will enter subintimal planes, but we do have devices and techniques where we can possibly track all the way down. For me, pedal will be more of a bailout, like a plan B in case we are like struggling and we're a subintimal plane or spiraling left, right, and center. Then of course, this pedal is a good strategy with healthy vessels down there as well. Karthik, are you on? Yeah.
Yeah. PK, can you hear me?
Yeah, now we can.
Yeah. Yep. Okay, so I would not go pedal on this patient first because I think the only robust vessel is the PT. AT is very diseased. Peroneal is not the dominant vessel. PT is the dominant vessel forming the arch. There is a nice hub right at the level of the SFA. I would go from the SFA. Definitely, if you go from the pedal, you need a lot of support from the pedal because you have a long segment. I would come to almost the distal hub. If you cannot go lumen to lumen, you have to dissect the vessel. If you cannot re-enter the vessel distally, then I would probably leave it at the distal hub, probably take a sheetless catheter and get into the dissection plane and then externalize the wire to keep the pedal axis as short as possible. But I would not go pedal first on this patient.
Raman, any different thoughts or pretty much the
No,
same?
I mean, I agree with the fact that I think we should give it a
Roadmap?
shot from above. I do agree with the fact that there's not that
Oh,
severe calcium
okay.
that would make it challenging to do the actual case from an antegrade approach first. The only thing that I would say is that I think that we may actually be able to enter within the true lumen distally. Whether we need to get pedal access to help us direct into that level, I think we'll see when we get down there. But I feel pretty confident that because there's no
Positive.
distal highly calcific
Yeah,
cap that we may be able to get right in.
1 second.
right. I think I agree with RD. I mean, if proximally we're not able to get through, pedal is a very good option in this case, at least like Karthik said, to guide us, get the wire up, still work from the top, minimal trauma, but I think we should not be hesitant to switch over to pedal if need be. But we'll see. But it's amazing how beautiful the runoffs are there for the vessel and the two vein grafts. You know, vein patency is supposed to be the best.
Don't worry about that.
And in good surgical hands, it should definitely give you good long-term patency. But in this guy, it's probably his protoplasm and I don't know his other habits which might have precipitated the failure of the graft itself. But looks like good targets, right?
Yeah, so I mean, listen, Raman and I have obviously discussed this with Twinkle. See, for us, I mean, one of the thoughts we did have is putting a wire in the pedal, just leaving a wire in the pedal. I agree with Karthik. Like to me, putting a wire in the pedal is multi reasons why I would do it. I mean, one is obviously I really believe by looking at the cap that we can cross, but I think this has a lot more thrombus than we think it is. Twinkle and I talked about the shape of the cap yesterday and the shape of the reform of the cap. It shows that it may be very thrombotic and may have a lot of crud in it. So a couple of things that for the interventionalists at home, one of the things you want to think about is, okay, crossing is a very good point. Everybody here has a different recipe to cross this, but I want you to think a little bit ahead as to what is going to happen once you cross it. Well, what are some of the pitfalls of crossing? Well, one is, Twinkle, can you go to the AT thing? So when you see the reconstitution level at the level of the AT, which Twinkle is going to show you in a second, what it's going to do is it's going to make you think of how this vessel fills. So if you see everything coming down, this is probably it. If you see everything coming down, you see the collateralization come in, fill first the AT right there, and then retrograde fill the distal pop into the PT. Now, you may have some distal reconstitution down to the posterior tibial through one of the genicular collaterals, but this is the major mechanism. So while you're crossing from above, you can't knock off that pop collateral that you see, which is coming out of some unnamed genicular collateral that's coming out of some other unnamed genicular collateral that's coming from the profunda. So part of crossing is going to be careful at that level. So that's why Raman and I thought that we should have PT access. Just if we get close and we have a big loop, it doesn't look good, well, are we going to be able to get in? So we've got an ultrasound here. We've got Raman, who's fantastic, and Twinkle, who's fantastic in getting this stuff, and I can always get it on the floor if I need to, and we can go ahead and cross. That's one thought process. Second thought process is once you cross, if you find it's very, very easy and it's full of thrombus, you have a robust PT, you could put a filter down, but with this much thrombus, it's going to be an issue. So one of the things you could do is put a balloon up through a 4-5 slender from below, put a coronary 5-0 balloon, obstruct the pop so you have massive distal protection, do all your angiojet, whatever you need to do up top, suck everything out, and then drop the balloon after you're done. You could do that as well. So, I mean, a couple of reasons. And third is finally, if you don't cross from above, and you're worried about knocking off the collateral, you cross from below and do what Abdul did, which is just go ahead and push it up. I wouldn't put a sheath for that reason, and similar to what Karthik said, because I think that you're going to need a lot more support than you think to get to re-enter in the mid SFA. So I have no doubt in our hands we could probably track down close to that reconstitution zone. If Raman needs to get access from below, push just a wire with an 018 Trailblazer up, externalize the wire with, say, a vert tip catheter and work from above is kind of what we're thinking. So these are all the different thoughts. As far as anticoagulation, we've done Angiomax, and what we're going to do is we're going to just get started. And then I also want you guys to think about, as we cross, what is your treatment strategy? Raman, I mean, as you know, this area in the pop is a very difficult area. Obviously, they're not going to bypass to it again, right? Because it's already occluded vessel. So how are you going to treat this? Was DCB? Is it atherectomy? Is it stent? If we're lucky enough to cross and if we're lucky enough to have a good result. So I'm going to cross while you guys talk about some treatment strategies. Me and Ray are just going to work here.
Great. So what wire and catheter do you have, PK, to begin with?
Well, this is just our standard angle glide wire and just a vert tip catheter, which we've been using for 20 years. Ray and I. So we're just going to go ahead and just slowly keep the loop small. try to just dissect down. And again, like I said, this is an area where we're going to we're definitely going to stent this. So the question is, I'm not too worried about this. So right here is an issue right there. So Ray's going to have to push down to the catheter, give me a little support here. And as Ray, let's see whether we can break through. So then that's the calcium you were talking about, Vishal. Right. That's right there. So again, the one thing, Karthik, just before you say something, is Ray's watching the sheet and how much I'm pushing, just with the pressure on the sheet. So you can see there's a lot of tension, so you don't want to move the sheet back as well. Go ahead, Karthik. Sorry.
Right.
No, we were going to talk about the treatment strategy. Atul, you can start. Like, what would you do once? I mean, we'll definitely cross. There's no doubt about that, knowing PK skills. But what are we going to do after that?
Pressure, huh?
No pressure.
So
really? He's going to cross antigrade. Trust me, he's going to cross antigrade. I'm going to put more pressure on him.
I think the most important point that PK and team is making is that when you come pedal, the main reason for my approach to pedal first was to save that collateral. So you can get across that collateral very safely. When you come antigrade, there's a fair chance you'll dissect into that collateral, I think. Because you can't control where you're coming antigrade as well as you can retrograde.
Let me
collateral
my loop.
is past the stump. So you can easily pass the collateral entrance into the, infra-popliteal vessel.
Might be in the vein.
And go up there. No. So I think you're going to have to do a lot of debulking here. But it looks soft in some parts and hard in others, in the sense of maybe there seems like there is more thrombus in there. And this guy was on Eliquis the whole time, which is a little concerning that he's getting thrombus while on Eliquis. But it looks like there's soft parts and some islands of more calcific or difficult parts across. PK, is that how it feels to you? Like it's going, like,
Well, yeah, there are clearly areas of difficulty, and clearly areas of non-difficulty. So I'm going to lose the loop here, which I don't like to do, and then try to find another area to get in.
Yeah, I think it just depends how the wire and the catheter behave, and like you can, like RD was talking about, it's just like areas where there will be calcification and real stenosis versus areas with superimposed thrombus. So if it's a lot of thrombus you are certain on your angiogram after you've crossed, then of course I would probably be, like PK was talking about, being a thrombotic burden right there. Might just keep a lytic catheter or just at least pulse spray it, at least decrease my thrombus burden down so we can make an educated decision to say, okay, are we ready to do our definitive therapy, whether it be DCB, atherectomy, stenting, or just hold on for 24 hours, lytic catheter, reevaluate and bring him back. But I think it just all depends how the whole wire catheter feel it is, and that's where the expertise lies. I mean, you can add your knowledge with IVUS and all those things, but in this case, it's more about how the vessel or the wire and the catheter behave. So we'll say, I mean, like you can see here, PK is it's like we were talking about being in the subintimal plane, which we expected, which is normal and nothing to be afraid about. It's all about getting back into the lumen, and there you can see he lost his loop. Sometimes what happens, the usual teaching is never lose a loop once you're in it, because that will give you enough pushability. But in his case, he was deviating a lot from the vessel. So once you're out a lot from a vessel, like Raman, you could overhear Raman say, are you in the vein? Because sometimes when you pop through the artery and it feels so smooth, you might be in the vein and not in the artery itself. So certain things to consider while you're crossing your CTOs to see how the wire is behaving, how the loop is behaving, is the loop getting bigger, smaller, and where you are in relation to your distal vessel or distal reconstitution. So I believe that's what he was thinking about.
What would you think is
So what's your feel, PK? What's your feel, Raman?
Well, it's very, very fibrotic. Raman, you can comment. We're talking here.
Yeah, I mean, I think it's really going to end up on what PK's answers here about what the feel of the wire is really, and as far as what's going to be the priority in terms of how much aspiration thrombectomy we may have to do.
What happened?
Yeah, and also kind of like how the patient is feeling as well, because it really does depend on how exactly we end up crossing and how challenging it is to get the catheter all the way down. I think if we do end up having to do some thrombectomy first, I think that will probably be a very likely step here, considering about what the likely thrombotic burden is, followed by the DCB, and we're gonna probably end up
get us a Navicross, guys.
The entire segment here.
Yeah,
I'm in a collateral.
Yeah.
So I mean, I don't know why PK, why are we so concerned about thrombotic burden here again?
Yeah.
Well, it's just the way it looked to me, the nub, but now it's not behaving like a thrombotic vessel. But I really think we have a lot.
We are in the dissection plane, right? Clearly from the top.
Right now we're in a dissection plane for sure.
But even on the top, look like it definitely wherever there is no calcification. It's going very
I
free.
need a
It's
new wire.
dissecting very
New
freely.
angle glide.
With that big of a loop, I don't
Yeah,
think we're in the
across.
lumen at
And
all.
a new
No,
angle
you're
glide.
great.
So I would probably not even worry about debulking this. I would just balloon stent it. I would DCB it and just stent it, or just directly DCB in the bottom, put a supera. I think you'll cross. I think you're very close to the hub. I think the collateral will not matter here because I think there's a big segment of popliteal which is probably underfilled. That's where probably they did their touchdown for the graft. So I think you will probably pop into that segment. So if you stent until there, above the level of the collateral, I think you'll be fine.
Yeah.
Well, I mean, to me and Raman right now, the way it's behaving, at this level is not behaving very smooth because the wire is deviating. So many things are happening. So I might just pull this back a little.
Yeah.
And
form a loop again and probably dissect it.
Right, and then see how it goes. I mean, that's one of the things I'm going to try here because we were going with a straight wire, and obviously a straight wire was good to break the cap. But now at this stage, we want to try to re-enter.
It's very important.
Guys?
It's very important for people to understand that, sometimes, especially when you go distally down where the reconstitution zone is, the visualization can become very tricky. You have collaterals coming in.
I would form the loop from above, PK. Don't you think it's going into the collateral, I think. It's dissecting into the collateral.
No, I know, but right now we're having issues following the loop. I agree with you. We're just going to try to form it here.
Yeah,
so
right there.
That's too big. See that?
Yeah.
See, that's way too big. See, and you can see there's a little bit of air and stuff right there as well.
Yeah.
In the vessel, you can see. I don't think it's air, but whatever it is, it's there.
Yeah.
So we just. I think we need to. So I think this is the area where I think Raman and I had planned.
PK, you think getting into the plane you had with the straight glide, and then changing to an 014 and forming a loop and going down.
More the 018 is what I was thinking.
018, yeah. 018
okay.
I mean, a smaller caliber.
Give me the.
You can take the Terumo
because
gold.
if you went into the collateral, that means you're definitely very close to the distal cap.
Yep. So let's do this. Let's get pedal access here. So Raman's going to work on getting pedal access with the ultrasound, and I am going to switch out.
You want to try to a Terumo gold wire and 018 Terumo gold to see how it navigates across?
That's exactly what I'm doing now, but I think Raman is going to get access because I know what's going to.
Yeah, it's just I think
happen here.
Yeah. It's just about like Atul was talking about, find the directionality and know exactly where it ends. So pedal access with the wire down will give us a little bit more, make sure how it's more coaxial, especially coming from the top, and we're not all the way around it. So
can I have the wire, please, guys?
I think the calcium right there is what knocked the whole system out and just deviated you off, causing that big loop.
Yes and no. I think that it's a very fibrotic post-surgical area.
You're just forming a bigger plane. That's all it is. But it's fine. I mean, if you're planning to stent it, which we are. So
it shouldn't make
really
a difference.
matter how big of a plane you form. So.
There you go.
Yep. So what we're going to do is we're going to go ahead. We're going to go with this 018, or I might go back by straight glide and leave it where it is, and then go ahead and try to form our come from below, break the cap from below with an 018 catheter, and then take it from there. Let's see how this 018 catheter behaves. Liz, let's turn off the max for a few minutes.
I'm surprised I don't see more calcium. Is it maybe just the image on my side?
All right, give me the straight glide.
No, it is not as much calcified as you think it is. I mean, there is calcification for sure, but the extent is there's more like focal zones.
Yeah, I think it's more fibrotic than anything else.
Correct.
I think that's what this is. This is pure atherosclerotic lesion. So
it's interesting. Usually with bypasses, the native vessels become highly calcific.
Correct.
And that's usually the more progression of the disease rather than the fibrosis and thrombosis. That's what seems more interesting.
That's good, PK.
Right.
It's a good one. Now, from there, probably you can try.
Yeah. So sometimes it's better to step down your wire because sometimes, you're forming big dissection planes or a smaller lumen like a 014 and 018 wire helps you find the channel relatively easier rather than keep going with the same 035 in the same direction. So that's what PK did, is change his wire to a lower caliber but a more hydrophilic, keeping it Terumo gold, and then trying to go around and find the right
PK,
channel.
You want to get the pedal access, or do you want to give it a shot with 018 and then wait a couple of minutes to see?
No, I think it's smart and prudent here to get the pedal access.
Yeah, it's fair. I mean, you can
I think sometimes, depends. At this point, it looks like, if you're coming antegrade only, or if you're coming retrograde at this time, where do you want to, connect your wires? You want to connect it in a larger vessel rather than a small vessel. So connecting a distal SFA would be more advantageous, in my opinion, than connecting them in the popliteal area. It seems like even though Karthik, I think you're correct, you're going to end up likely putting
That's a
on
good.
the top anyway.
Yeah.
That's a good direction of that wire.
1 second.
Yep. So Raman is trying to get access here, and
Yeah.
I think it might be the vein.
Wow.
there.
No, this
And it looks like artery.
artery.
Oh,
Okay,
yeah,
that's
yeah, yeah.
Raman's good. So we're just going to put the. I'm going to show him a little bit of the fluoro here. Can I let go for you and move it or no?
1 second.
Yeah, you just
Don't
you can
move.
put in a
Yeah, show me.
dilator of the micro catheter and just put the long wire in. That's all it should be right now, because right now we're not trying to cross. Just give him the directionality of where our wire is, the top wire in relation to the distal wire. So
That looks good.
That looks good. Okay, just put the
How
dilator.
does it feel, Roman?
Feels good.
All right,
Take a
good.
puff.
So what we're going to do is we're just going to, again, we don't. Let's take a GSA picture. Inject. Just want to make sure we're not in the vein. You know, he's moving a lot. He's not exactly the super cooperative in this situation. So we're just. Yes, there was nothing. There it is. Something is coming. There it comes. You can see the flow is very, very poor. Yeah, we're in the vessel. Good.
Yeah.
Push the wire up, Roman. So you can see it's a very robust PT.
the ET is good size. But yeah, PT is the main vessel.
Yeah, well, yeah. Okay, we're in the PT there. So we're just going to leave that there for now.
Put the teeth
And
in.
Roman's, I wouldn't put a sheet though, just put the dilator.
Yeah.
Just put the dilator of the micro sheath, and you can put a long wire up there just to give you where it
That's
enters.
just the dilator.
Maybe just fly.
And just do me a favor, just put a
This should-
dilator.
Yeah, this should be the dilator.
And then go with a fielder wire up into that thing, and if it crosses, it crosses, and then we'll externalize it into the sheath here. So give them a fielder wire from below, guys. So again, I think for the audience at home, this is just kind of a
Raman,
little
you're giving them
advanced,
medications, right?
a little advanced planning here on how
We're
we're
just
doing.
getting this area free of sharps, but yes, the same cocktail that we always talk about: nitro, verapamil. We may leave the verapamil given the
No nitro, please, or be easy on the nitro. His pressure is very low.
yeah, easy with the nitro. Something that I'm very good at.
Awesome, great. So you're gonna continue PK with your top with an 018 wire?
Yeah, we're just gonna try to dissect down. Me and Ray try to push it down.
All right. Yeah, fielder.
Yeah, there. 1 second. Let me.
Yeah, that's good.
Retract it, Ray, a little bit. Can you let go of this, Roman? You're on my way.
Sorry.
But I think it's still in line.
And PK, you switched from your vert to a
tracking.
Navicross?
Yeah, it's not.
Yeah, the
tracking.
trackability, I think you took a Navicross because it's easy to track down.
No, he's
Alright.
still on the word.
No, I'm still
Is
in the vert.
He's
Oh, you're still on the
word.
word. Yeah, still on the word. Sorry. He's asked for a Navicross, not doing it.
Yeah, I think this is very fibrotic here.
You
Yeah.
want to take an Astrada or something like that, PK?
Not yet, because I think Roman's going to cross from below. I think we're okay here.
Yeah.
That was the whole idea. Wait, don't go blind, Roman. So you can't go blind.
Take the
Not
loop
go
if you
blind.
get it, Raman.
Okay, now stop,
That's
slow,
why I
slow,
don't
slow,
like-
slow, slow, please. All right. Let's do a DSA here, guys.
Injecting.
Ready? Put it away. Before you do anything, put an 018 support catheter on that, please. Put an 018 support catheter.
You have a trailblazer.
Yeah.
You can put a 018 Trailblazer. You can put the 018 what is it called? Actually, I like the Cook catheter. Give us the Cook 90.
CXI.
Give us the CXI 90, please.
We have a blazer open.
Okay, we have it open. Use the Trailblazer.
No, he just wants to cross from underneath, below, and then just try to connect it up
This is
there.
not
PK, do you need an
300.
018? You can't just use an
Oh, this should be.
014, you
This is
think?
300.
No, we're going to use an
Oh, yeah,
018 Cook just so we have the option to go with an 018 wire if we need to.
Ah,
So that's
right.
very important for everybody at home. I know that we all think we're really good at what we do, but the honest truth is you have to be very, very humble and figure out that you might need to upgrade these wires to different wires that are available. So right now, Raman's up there at the level of this cap with the fielder wire, but I'm not going to cross this with the fielder wire.
I
with
was
this
going to
one,
say,
with
Yeah.
this particular fielder wire, because I think the fielder wire here is
Trashed.
quite damaged.
yeah.
So we might go with an 018 Terumo Gold from below, and then
Okay.
and then we're going to go
Another
ahead and
gold.
push it up from below. So get us an 018
Got it.
Terumo Gold from below.
I was thinking, if, okay, A18 is fine. I mean, I would have probably kept an option on O1 for maybe like an Abbott command wire, which is hydrophilic with a little bit of support.
Okay,
Because it finds,
I
again,
don't think,
it doesn't
absolutely
matter,
don't
I
think,
it doesn't
I
matter. Yeah, sure.
Guys, I absolutely don't think you're wrong. Let's go with an 0-4 command wire, and let's see how this goes. Get us a command as well. Go. So Raman is just pushing it up very easily, and if he's, I don't think he's having any issues. Twinkle is giving him a nice support. Is it moving?
He's not.
There it is, slowly, yeah. And again, I think this is very good technique that Raman is showing, because you want to take your time. You don't want to push too much. The key is you can't let the wire dissect up and get a plane, and then what that'll happen is that'll create a problem as well. Okay, good. That's enough for now. So let's go ahead and switch out to another wire. Actually,
I guess we
missed
the
damaged.
Oh, beautiful. I guess we missed the smack on the left hand of Raman. Raman, we didn't see that, right?
No, Raman never. No. That only happens when you guys pull the filter out.
Oh my lord! This is what the Karthik 7th year, the 8th year of filter.
I don't want to get into comments. No comments.
Unfortunately, Karthik has never done that.
No comments. I don't think even Vishal has done that, but no comments.
It's okay. I have. That's why do you think I'm in the moderator room now long? PK doesn't let me scrub.
No, Atul actually commented to me. He said, "Listen, PK, make sure Vishal doesn't pull out the wire." So, I mean, Atul has been very nice to Vishal usually, but not today.
We've all been there. Anyone who says differently is not telling the truth on this meeting right now.
Exactly.
The ears have changed.
That's a good direction of the wire. If you get the catheter into that hub, that direction.
We're trying, brother.
Yeah. That might be actually give you a better support. I think that's a nice direction.
Yeah, I think it's a good idea. That's true.
It's breaking off.
You were there.
For instance, you guys were talking about 3 different kinds of support catheters. Navicross,
all right, now get the Navicross up. Ray, why don't you help Raman from below?
About them in reference to which ones you prefer to use?
Well, I think it's more of a personal preference of how you like. Some people like CXI. I like CXI better because it gives you more support. But again,
this is a Terumo Gold?
Yeah.
Wow.
Okay. Okay, good. All right, now let me give you a roadmap.
Yeah, it's just might have to change to us to for
turn on the max. Ready?
From above.
Give us a Confianza, guys.
Yeah.
I would just change that for a Confianza. Don't move your legs.
I would get the catheter close to the hub and then change it to a Confianza.
Don't move your legs. Inject.
Moved again.
Okay, we're trying to save your leg here, so please don't move your legs, sir. We are trying. Your heart doesn't allow us to put you to sleep, so please understand we're doing everything we can to help you. So just, if you're in pain, we'll give you pain meds. Liz?
Okay, we'll give it one more shot.
Okay, good. Get him the, it's going off to the collateral. Get him a Confianza, guys.
No.
Yeah.
Let's get this a little bit higher up.
No, I think with the Confianza you'll be able to go because this will dissect up. I'll just push it up. You just hold the wire. Push the wire. Pull the wire back. See, that's what I don't want. I want to go there.
Yeah. Okay, so that's a good spot.
Okay.
I
think you can just
you can
push
try
it
now,
up.
PK.
Try
now.
The wire now.
And make a loop and see if you can go.
I think it'll go.
Just promise it's going to get into some small little collateral.
Yeah. No.
So. I think he'll make the loop immediately as soon as he gets out.
Let's see. I hope so.
Some forward tension on the catheter.
Yeah, but that's not the loop you want. No, get him the Confianza. Trust me on this. It's very fibrotic.
Yeah.
Okay. Confianza, guys?
Yeah, we haven't.
Go ahead.
Yeah, heavy tip.
Give me a Confianza from above, guys. Give me a Confianza from above.
So far.
I think that's what we anticipated was the popliteal region where it'll give us all the trouble getting in, getting out, especially as the taper of the vessel starts to go down. The flexibility of re-entering it just becomes even harder, especially with the disease distally into the
So why don't you guys tell me how you would treat this if we're lucky enough to cross? How would you treat this?
We'll cross. Atul, you want to go ahead?
Yeah, I think Karthik mentioned it earlier. I think I would put a Supera down in that popliteal area for sure. I think you're going to have to. I don't think you're going to have anything.
What size Supera would you use, Atul?
I think a 4-5. Lower down. Obviously, you want to take a look after your dilatation, but I would probably go. How tall is the gentleman?
He's tall. He's quite tall.
Then
Liz, how tall is he?
2nd.
But I'd probably stay with the 4-5.
Well, yeah, I don't know. For me, is we have to see how it does. If the proximal AT, how it looks is it's looping and dissecting, I'm sure there's fibrotic disease. So I might have to put a drug-eluting stent there and do a supera proximally. Now the 4-5, I don't know. Me and Karthik have a little bit of different strategy because 4-5 is the degree of restenosis we've seen, and also from the data, is 4-5 is much higher. So 4-5, even though it sounds appropriate for the sizing, it might we just are hesitant to put in a 4-5. Usually a 5 or a 5-5. Depending on how the vessel reacts. If it's a male gentleman, you might be able to at least squeeze in a 5 or maybe a 5-5-2, depending on how we dilate and how the vessel looks. It's probably all a hibernating vessel, distally down. So for me, 5 or 5-5, again, after ballooning, it gives you a good idea. Would probably be the strategy. But I would probably just drug coat it first, put a supera distally, and then see how it behaves proximally, and then stent it as and how needed into the SFA region. But we'll see. But that AT region, you would definitely have to stent as well, which probably I might end up using a coronary, one of those new Megatron stents where you can dilate them. They have more elasticity to them, so you can actually dilate them to bigger sizes than what they come with. It gives you that taper sensation.
Yeah,
So if you're planning a drug and then stenting, why not just put a Zilver down or another drug-eluting stent platform?
Yeah.
Why use all your bank account in one case?
No, I agree with you. I mean, the Zilver, even the data suggests the fracture rate has been significantly low. It's not significant fractures compared to other stents. So you can use a Zilver as well. I mean, you're absolutely right. But how people joints, they prefer supera, especially based on the data. So you could do DCB or you can do just straight up Zilver. But again, it depends on how far you have to stent. If you have to use 3 Zilvers, then you're losing a lot of money as well. You can use a long 250 DCB and do a spot stenting. So again, you're right. Now we're going to the economics part
This should be
of it
okay.
as well. But now look at the wire. It looks actually in a good direction.
Stay there.
So it probably, I think, is going to track his microcatheter up.
It's not
A
going.
little bit further.
Yeah, it's all fibrotic.
This cap is
All right, do me a favor.
very-
Walk this out and put a 014, what is it called? This one, teleport on this wire. Keep going up, but you're going to need a teleport before you go up. So don't bother crossing, because if you cross, you're not going to be able to track the catheter up. So wait till you get the teleport changed out. Give me an 035 wire here, Ray.
Yeah.
Straight.
I mean, for people who don't know, teleport is one of those 014 coronary microcatheters used. Most of the time we using the coronary, has a very low profile and good crossability. So that's what Karthik was talking about, that 014.
That's why I was going 014 first, because I thought the trackability is much easier with the smaller catheters, especially. You can always upgrade it. Now I think Raman will have a problem with oozing around the site once he puts an 014.
No,
which is okay,
are you kidding? Come on. Oozing
it's okay.
around the site.
It's fine.
Please. Come on, you got to be oozing 014, 018. Give me a break. Come on.
Nothing that a little gentle pressure.
No. If you make a comment, it's got to make sense. I mean, oozing around a catheter 014, 018 is irrelevant.
It's going to ooze, PK. But that's fine. That's okay. That's why I'm saying it's okay.
No, but I mean, you look that comment. I absolutely disagree with, because you need to go. You need to go with something that's gonna work, because of the fact of the tensile stent of the catheter. You have no way of predicting whether it's going to cross or not cross, guys. So let's not pretend that we do. So
all right, let's talk. Yeah.
We've Vishal, please don't cut me off. Please don't cut me off.
Sorry, I didn't mean.
Okay, but very, very clearly, I want to make clear that there's no 100% answer here.
Yes,
there's no 100% answer. So let's not sit here and be dogmatic one way or the other. The reason why the audience likes us is because there's no 100%. We're the first ones to agree it.
That's
so please don't say that you knew that the 018 catheter was not going to cross. I mean, that's a ridiculous statement.
You got wire?
Mm-hmm.
Send it down.
All right, get me a Terumo.
So you're using an 035 still the wire from above, PK?
Yeah, I just wanted to get closer for him. So I think the way this is going to cross is from below. So let me push for you, and why don't you rail the wire? I just want to get him. Give me a Navi cross from above, guys.
Yeah.
Rail, Raman.
Yeah.
You're railing me.
Yeah.
So now I think we're going to go ahead and push this forward the way Karthik is saying. I need a dry one, guys. It's not working.
Yeah, are you getting stuck? You want to pan down and see where it's getting stuck?
No, it's up there, Atul. It was just it was sliding on my hands. So now what we're going to do is we're going to let him push from below, and then hold on, maybe hold on. So let me just get the catheter from above. Maybe you'll be able to just cross right in.
Yeah.
Which I'm praying. Let's see. Let's see. It would be nice if I can get him a little closer here. No, that's not it. See, that's not where I want to be.
And I think another good point is always take an angled catheter. Like you take
Yep,
an
exactly. That's what we have from above.
Yeah, not a straight one, so it gives you more steerability.
Raman, you are not able to go forward, or?
No, I am. I just feel as if I'm being deflected a little bit in the wrong direction here. Because it looked much more
I think your
straight.
direction
There
is
it
pretty
is.
okay.
PK's direction looks
PK's
good.
direction looks
Yeah.
okay.
Yeah, but
as-
look
as
what's
long as
happening,
we
Vishal.
stay-
It's gonna go off
Loop
to the
big.
side.
Yeah, you're right.
It's
So
very,
you were-
very fibrotic.
Yeah, you were right. Initially, a wire was in the collateral, and now it looks more coaxial into the
Yeah,
vessel.
this
You're
is
right.
really,
it's very
really tight. There it goes. Okay, hang on, Roman G. Coming to you.
Special delivery.
Yeah.
Okay, hold on.
There's
Oh,
There it is.
That's the wires,
that
right?
that was really important. You guys saw that.
Okay,
There
hold
was
on. Let me
a
mag
lot
up for
of
Roman.
interaction.
Yeah.
And whoever's rotating the camera, that's great because that's showing us that you're really lined up nicely.
That was actually the patient on his own by rotating
that's
his,
leg.
his leg.
So, Karthik, Vishal, would you advise to pull out my wire now?
I
Or
would
would
not.
you-
I would still dissect it a little bit more.
A little bit more
Let's see.
coaxial.
Make
Let's
a
see if
bigger
Roman can
plane.
just enter somehow.
Yeah, exactly. Raman can
It looks
push up a
like-
little bit more.
Are you-
No way.
yes, well,
No.
let me give you a little support. Hold the catheter for you. Are you in? No, you're not in. You're on the side, aren't
Yeah.
you?
I would
Okay,
dissect
not
it a
yet.
little bit more, PK. It's fine, right?
Yeah.
I mean, what's
Stay there,
what's
Roman.
the
We're
harm?
close.
The ha-
Yeah,
no,
but
I
still the
agree.
collateral is more distal right now. We still have enough
and
room.
as soon as you dissect it,
Yeah,
I think
see,
Raman
you
should
can
just
see-
pull back and re-enter it.
No, I agree. Let me just dissect a little bit more. Let me lose my loop a little here so I'm not going too big. Okay.
Yeah. Raman,
hold on,
now
Roman.
you should pull back.
Yeah. Now
And
it
then
looks good.
now you should pull back your wire and try
And
to enter it
redirect.
into the
Yeah.
catheter.
Pull back the wire. And try now. Ray, torque the catheter for him. There you go. I think you're on top, Roman.
Can we see a different angle?
Yep,
Raman, you
I'm
feel
try-
like you're
I'm
touching
try-
it, or?
No,
No,
I don't actually.
Oh,
I think we're going right. We're probably right on.
I think we
top
just
of-
probably, yeah, I don't know. Does your micro
Which ca-
catheter track?
Which wire? I'm going to try to track the microcatheter now.
Yeah. See if it gives
Hold
you a
on a
little bit more
second, Roman.
support.
Hold back a little. Ray, give me an 014 wire from above, guys.
Unless
there
you're
it
in two
is.
different
There it
planes.
is.
Yeah.
Come on, push it up. Let's see. Nope.
No.
All right, give me,
unless
give
you're
me
in
an
two
014.
different planes,
Yeah.
which is fine.
We might be, which I think, like you said, Karthik, we're going to be able to
Man.
dissect it down.
It's fine. I mean,
Take
you
it.
can still dilate it with the balloon and
No,
get
I
into
need
the
a
No,
vessel.
no.
confianza. New confianza.
Yeah. Could just do like a facilitator reentry.
Yeah,
at-
we can do.
at-
We
at this
can
point,
do a
yeah.
kissing. We can do a what is it called? A card.
Card technique. Yeah, it should be okay.
So what I
No.
would probably think about is you want to exchange for an 014 also coming from the top and see if you can puncture through the lumen into the distal cap.
I will. I think what I'm going to do first, Vishal, is come with an 014 wire down from above,
Right.
and then try to see whether I can get it into Raman's catheter, because sometimes the planes are different, and both of us working together might be able to do it. My
Right.
only worry is, am I in the vein from above? I might be.
I don't think so.
I don't think
you don't
so.
think so?
That
No.
much
I know.
difficulty you should not have in the vein. I think
Yeah.
you were already in a collateral. I think it.
Especially
Might
a
be.
loop, the way it was behaving if it was vein, we would have
One
thrown
second, let me
down.
pull back a little
But the
now,
way
let me
you're
come
stuck
from
with the
above.
loop, I don't think you're in the vein. Doesn't.
I hope so. I mean, we'll see. I mean, it's so hard to tell. I mean, this is where I think EES also helps. External ultrasound will also help if we
Right.
had it. I think that's another thing that we could have done to see where we are. But it's a difficult area. Yeah, there we are. Let me see if I can.
Yeah, move.
Can I get a torquer? Can I get a torquer?
And Raman, were you having resistance as you were going up, or were you just trying to get in the catheter?
No, there was a tremendous amount of resistance.
Okay.
But remember,
Tremendous.
right. So I'm sure there's also support, like Karthik was talking
He's
about.
in. He's in. Save that,
Right
guys.
there.
He's in. See that? That's how you create the plane. You see that now? See,
Right.
Raman touched my wire. Now he's gonna push it right up. Push it right up, Raman. You're in.
In the catheter.
Let me push the catheter
Slowly
for you.
bring it in.
Yeah. Hold on.
Now take your
we are.
micro catheter and
Alright.
put it in the other one.
Yeah, but I'm
It's
trying. It's
married.
not. It's not going.
Yeah.
I'm just bringing it slowly in.
No, it's
Yeah.
not going.
You can
Okay.
just
Push the wire all
externalize
the
this
way up.
wire. Just keep pushing the wire.
Pull the-
Yeah,
I
that's
know,
the-
I agree, Karthik.
No,
Yeah.
that's
Why
definitely
unnecessarily change the
the
distal
plan
cap?
now. No, but the issue is just the amount of tension required to get it.
Hold on.
forward.
I'm just trying to see what I'm doing. I'm pushing from above, And
Into
just-
the-
Just slide it over the catheter and see.
I'm trying, Karthik. Yeah, definitely.
I know
I
it's
agree.
easier said than I know.
Yeah.
Because like he was talking about, the sheath is not there. It's a teleport, which is a very fine lumen, so it doesn't give you enough support. It gives you crossability, but it doesn't
Push
give
the
you
wire,
support.
Roman. Push the wire all the way up.
And the
Push
wire is also like a.
not going.
No, I think it's not going for him.
Right.
So I can see Raman is actually using.
Oh,
a lot
it's
of
it's
force.
buckling. It's buckle. Go distal.
Careful, careful, careful.
That's okay. If we lose it, we lose it.
No.
My rule is always, if you did it once, you can do it again. All right, hold on a second. Walk this out. Give me the Cook wire now. Give me the Cook catheter. Walk this out, Roman. It's okay. Walk it out.
No, push the
Just-
fielder all the way.
It's the fielder's not
not
going.
fielder.
Chief.
I'm sorry.
no,
It's not a long
it's
one.
not
That's
going,
true.
Chief. It's
Sorry.
not
sorry.
going. It is a long one. It's
Can
just
you
not going.
can you get the catheter up if we just rail this?
Yeah, just pull it out.
No, if you just push this up,
Oh, so you're saying the confianza wire is not going all the way up? Okay, I get it.
just get this into the
Into the other catheter.
yeah. If we can get it into the catheter,
It's not going. Walk it out.
No.
It's a lot of motion on that teleport down on the.
Mhm.
on
Yeah,
the
because
skin.
there's support.
I would just walk it out.
It looks like it's moving outside.
wants
of
to-
the
Oh,
Do-
you pulled the wire out. All right, give him a fielder wire, please. Give him a fielder wire. Yeah, it went back in. Give him a fielder wire. Oh, give him a command. Command might go in. Give him a command. Give him a command.
Because do you want to? I think it's just that cap, which is the problem. You want to push that. Try to see if you can push the word tip down a little bit more, or it won't go.
I'm trying, dude. It's
Okay.
not going. See?
No. Okay, that's
Yeah,
fine.
it's
That's-
okay. I mean, it's a
Yeah.
it's a fibrotic cap.
Yep.
That's
Just
all
walk this out, guys. Walk this catheter out. Yep. Mhm. Just walk it out. Just
Take
walk it
this
out. You're
out.
doing great. Just walk it out.
That's fine. If he can get in once, he can always get in again. I think he's already formed a path. So
He's already formed a path.
Yeah.
Exactly.
Probably use an 018 CXR or something stiffer, and then you can.
I can
put
see
the-
Raman like flexing his biceps. So he's really using a lot of force. So
Okay, it's okay. Just
So-
push the wire. Okay, you're out now.
get the catheter.
Yep, you're out. I'm just pushing this wire up now. Hold on.
4,
yeah, now try it. Now push it without the catheter.
Ah,
I think the
it's
straight. I
looping.
think the straight one.
It's looping here.
Just looping.
Uh-oh.
All right,
looping.
all right. Give me the CXI now.
Yeah.
Is this a confianza?
The Confianza.
Yeah.
Get the wire.
Yep, I got the wire.
Yeah. So that's one important thing to consider, especially go pedal in these CTs and fibrotic regions. Is like the support from down
Liz?
below is the biggest limiting factor. So yeah, I mean, you have to be ready for giving stiffer support catheters or stiffer wires or a combination of both to really be able to cross. So it looks easier. So
Otherwise-
up and over, we have sheets and everything right there. We have other devices, but going from pedal, that's one of the issues you'll always encounter. So you have to respect what there it is, and that's what he's trying to do, is manipulate his wire around, give a little bit of more support catheter to see if he can straighten it out. Otherwise, these wires
wire,
and everything
guys,
starts
above?
to straighten up. So something important to consider.
Yeah, I also think a sheath is not unreasonable.
Show me a little lower.
Correct.
You'll get, it's that you also lose. You're definitely losing something in the mid shin, but you're also losing something at the entry point.
True. That's correct. Yeah. So that's always something to consider.
All right, change out for a 014 command wire now.
Mhm.
Take out the wire. Go with the command.
So sometimes what you can do is, it might just sound very, it's like exchange this for a Corsair and then just try to drill it over if it's fibrotic and then go up there. So that's one of the strategies you could do if it's really not crossing anything
All right, I
so
just crossed from
fibrotic.
Went
above.
into the catheter. Yeah.
I
you
just
cross
crossed
them
from above, and that's all. Save
That's
that.
one way.
Save that from above.
That's
I
another way.
would, PK, I would stop the wire there and then probably just pull
Yeah,
pull this catheter out.
Yeah, you can walk the catheter out now, Roman.
Yeah.
I'll just pull it into the posterior tibial. And then what I'm going to do is leave the wire. That's
Pull
it.
it
Leave
out.
it there. No, why do you want to pull it out? You're going to bleed, right? You're worried
Yeah,
about.
ooze.
Remember, you're worried about bleeding.
I know,
Don't
but you
forget.
can, why do you want to leave the catheter there for spasm time?
It's not going to spasm.
It's
Well,
a
just-
single vessel. Why would you leave it?
No, it's 3 vessel. Okay.
It's fine.
But you're right. It's the dominant vessel. I totally agree with you. All right, let's take it out, guys. Let's take out the catheter. Listen to Dr. Guja.
Catheter out.
Yeah, because we're crossed. Ray, now give me an 014 long 40 balloon, guys.
What's the wire you use to cross from the top? Confianza again?
Confianza, yeah.
Okay, so it gives you support. That's good.
Mm-hmm.
All right, so this is just the beginning. So we still have a long way to go because it's to
long way
figure
to go.
out. Yeah.
No, listen, this is the bulk of the
No,
case,
it's
right?
from the teaching perspective. Yeah, I mean, it's a lot of things to cross, dual access, trying to connect the dots. Next strategy, I'm sure, like
the,
we were
the
discussing,
only
is
question
the new card or
here,
reverse
yeah.
card.
Now let's talk to
Yeah,
Karthik,
now-
Karthik and Atul. Do you guys balloon this? What do you guys do here? I mean, in terms
I would
of
just balloon stent it.
you would just balloon it.
I
Okay.
would take
Yeah, I
a
was
6
doing
balloon,
Karthik.
balloon it, and stent.
Well, 6.0 is not going to cross right now, right? So we're
Yeah,
going to 4.0.
I would use a 4.0 first, then 4.0 long, 6.0, 5.5, and then DES on the top.
I totally
5.5
agree.
super, 5.5
But you know,
super in the bottom.
Atul's point about the DES down below is also a good point, because as you guys know, we have a what is it called? A 1.8% fracture rate at 3 years, right? With the Zilver PTX, you're delivering drug as well as you're delivering your stent, your scaffold. So, and you're saving a step, and you're definitely saving money. Any thoughts on what you guys would feel about the DES here? I mean, at the level of the POP, only knowing that it's going to be a 6.0 because they don't have a 5.0, which I think may be an issue. So that's
6.0 is fine. I
6.0
think distally, I think the vessel is at least 5.5.
Okay.
At least.
Okay.
So I don't think 6.0 is
So
not a bad
I'll
idea.
balloon it, see how it behaves, and then we can, like I said, stent it. We definitely need to stent. We've been in dissection planes, fibrotic ends. So if you have to keep the patency of the vessel, I would definitely stent the distal
PK, you
part for
can't
sure.
take a overnight 6.0 Pacific plus or overnight balloon, overnight 6.0s and directly just balloon and stent it.
It
I'm
won't
so
it's
I'm
just,
so worried
overnight.
it's not going to cross, Karthik.
I know the problem is the
No, I know,
crossing
but
profile.
because you had a tempo aqua, right?
Yeah, but not
almost
all the
there.
way. Not all the way though.
It's okay. Well, it's okay. One
I-
extra step of 4.0 is
I
nothing
don't
wrong
think
with it.
I don't think I'd take a 6.0 down there first.
Yeah,
I would
yeah.
open it something
Come on,
smaller.
you
That's- I
boys
think
go
that's what
back.
he's doing.
Let go lower.
There's
I
your
think it's not a
balloon.
bad option. Take a 4.0, dilate.
Let's balloon the
6.0.
track here. Let's balloon here. So we're going to balloon this track. We're not quite to the distal cap yet.
It's
So
not
we're
crossing.
It's not crossing, bud. Okay. Okay, let's go up.
Let's take a coronary balloon.
Yeah,
to
it's so many
open up
planes
that.
with fibrotic and stuff. It's hard
It's
to
underneath
cross.
you, Ramanji.
Sorry.
Thank you.
Got
Let's
it.
go up. All right, let's go. You got to crack it. 6, 8, 10, 12.
Yeah, that's a long 4.0 balloon.
Yeah, it's a 200.
Yeah.
Okay, down. Let me get some speed here. Fluoro. So, I mean, the whole idea here is, as I was saying with Karthik and you guys, is that, we need to try to, preserve this collateral if we can distally. Wow, damn things are not moving. Rail, guys?
Yeah.
I think a coronary
I
balloon.
mean, it's not
Coronary
moving. Just
balloon,
take,
please.
just take
Yeah,
a
take
coronary
it.
balloon,
Take a-
dilate the track,
walk
and
it out,
just
somebody.
keep moving on. Yeah.
Let me just check my sheath again because we were pushing quite
So I
hard
would
from
still
above.
proximally 4.0. I'll still balloon the whole proximal 4.0 if the balloon is already in there. But
Yep, yeah, let's balloon I agree with you.
The whole
Vishal.
track.
All the way up, yeah.
We're going to
Let me
balloon the
hold
whole
that.
track.
I'll
it's
hold that.
already in there.
Yeah.
Just balloon it.
Uh-huh.
Yeah.
Okay, let's balloon this part here. Go up to 20.
So it seems, I mean, if the patient is wide awake, he's not having enough, not much pain. I know it's a 4.0 balloon because sometimes if you're deep into the subintimal and the adventitia where the nerves are,
Down.
they actually feel the pain. So that means you are
Walk
pretty
back
much
a little
closer
bit
to
more,
the
brother.
lumen, or at least in the subintimal and not really in the adventitial space. But again, it's a 4.0 balloon, so we'll see. But that's another one of those, gives you a rough idea of where
Quick
you
to go.
are in relation to the lumen, some indirect markers to look into.
Or Elizabeth gave fentanyl just at the right time.
Right.
Good 20. Down. Give us a 4.0 coronary balloon now. We'll walk it out. Let me see where the distal wire is. Oh,
Actually, not.
Not too bad.
okay, good. That's fine. Walk it out. So I think it's very good here to keep an eye on the distal wire as we walk it out.
Is the microcatheter from the pedal access out also?
Yes.
Yes, it is.
Yeah.
Is there any oozing?
There's a little bit of
Yeah.
oozing.
Trace. Yeah, just lay a little bit of pressure.
There
A
is
little
no
bit of
flow there,
oozing.
so it's okay.
No, there's
No,
flow
that's
there.
Atul,
Yeah.
PK is again going to say Karthik is concerned about oozing. You want to hear that from him? That's what it is.
That's exactly
That's
why
exactly
Listen,
what you want to hear.
listen,
Right?
I-
I'll
no,
say
listen.
it for you if you want.
I want to explain why I was so vehement about it, because I think we cannot be dogmatic. I think
That's fine, PK.
when we
After
don't have
so many years, me and Vishal have already been used to be your OBM, so it's okay.
Oh my God!
It's totally fine. I mean, Atul is new and Raman is new, so they're not used to it. After like 8 years, they'll get used to your
No, dude,
your dogmatism,
you
whatever you
cannot
say
be
that. So
you cannot be dogmatic in endovascular. There's not enough
that's
data.
absolutely fine.
It's
Yes.
it's all just our anecdotal understanding of how these lesions work. Oh my goodness, look at this. Oh, all right, go up here. Let's just. Wow.
That was tight.
That was really fibrotic. Get down. I think get us a 2-0 coronary balloon now. Wow.
If you get the, you're
I think
still on the
that's-
soft part of your command. You think you can get the wire down more, PK?
It's not going, buddy.
No, I'm saying your wire down. Your wire
I
down
can
into
try.
the.
Yeah, I can try.
You might get into the stiffer part of the command, and you might have, or whatever that
No,
wire
this is a
Fielder or-
confianza.
But I mean, I'm
You
so
already did.
surprised. I'm so surprised, Karthik. It's
Yeah.
not going.
It's a 3-0 balloon. Right?
No, 4-0. See? Wow. All right, give us a 2-0.
All right.
2-0
I
and then a
think
3-0.
this is interesting. I wonder if you if we left the microcatheter in, whether a balloon from below would have gone.
Yeah, but you know, I didn't want to put a
You
sheet
don't have
from
a sheet
below.
in there.
I
I
completely
did not-
agree. I'm more
Yeah.
curious because the way it tracked from below, whether a balloon from below would go. I mean,
I mean,
No,
even
but
from below, they were
usually
not able
even-
to track.
Yeah.
Right?
Even the
Even-
the
even the
teleports
microcatheter-
did
yeah,
not go from
Did
below.
not go.
So
If
really,
the
like,
teleport did not go, that means nothing will go.
So guys, get us a guideliner. Get it ready. 1 second.
Teleport
Hey,
is
still,
almost
my
like
friend.
a 1-0, right? So, right?
Yeah.
Teleport is almost like 1-0.
Yeah, I think it's just that fibrotic area where PK was talking about where they had to enter is what it's the problem. But I think, yeah, just serial dilatation with a
Right,
coronary
scrub out and
balloon.
just feel his
You just have to
calf
break
and all
that
that.
cap.
Yeah.
Once you break the cap,
Yeah.
I think.
just scrub out and feel his calf. Laura?
Yeah, dilate it there. I think you got a little bit of purchase there.
Okay,
You might
go
have
up.
to break.
I think we're gonna have to do a laser here. Well, we're just checking to make sure he's in line. Die, Ray.
Ray, I think you should.
Okay, down.
Now it will just go
Oh,
down. Bit more. Again.
and a little further.
wow.
Again.
Wow.
Good try.
Very.
You want to
very-
go up again, Raman? Just keep
Yeah.
breaking it, I
Yeah,
guess.
going
That's
up
all
here,
it is.
Yeah.
No, but it's amazing how a balloon, a coronary balloon, is giving you all the trouble. Look at the expansion. It really doesn't. Wow. Very interesting.
Almost there.
Okay,
Almost
all
there.
right. All right, give me a guideliner, guys.
I think TK getting the laser ready is not a bad idea. I think you got a
6
good
French,
point.
yeah.
Or a CSI, we might be able to, but we're in a subminimal plane.
Yeah, I think that's one of those important.
So you're going to put a guide and a guideliner on
This
top
is
of it?
this
just
is
a
a
fit.
NC. Do you want to try a
Just a-
Yeah,
compliant
give us a
balloon?
compliant 2-0
2-0
balloon, please.
compliant.
Compliant balloon. Guideliner. Or else, you know what? We could try to shove a Navicross in. Ray, give me the. No.
Stay still, my
Ray,
friend.
Ray, try to give us a Navicross.
You want to try?
We're
you can
giving
try
you
Sapphire.
medicine.
Navicross first? Okay.
Yeah, 2-0
How
compliant.
about a Sapphire? How about a Sapphire 1.0?
Exactly. That's our next
Yeah, I mean,
step
yeah,
here.
we can go down to a 1015. Yeah, exactly.
I
One
think we
will
started to make
recoil,
some progress with the 2-0 NC.
Yeah,
I think a 2-0
I think
compliant balloon may be all that we really need.
I
here.
agree
But
with you,
the
Raman.
support
I
with the
think on
guides,
that I
with the
agree.
Godzilla, I think will really make the head.
Yeah, but it's very impressive that even a 2-0 coronary balloon. I'm
Yeah.
still surprised the way it's behaving. I thought it would have cracked open on a 2-0.
There was some foreshadowing when even the
Okay, good.
the
That's good.
teleport from below would not go down. Do we have the 2-0 compliant balloon?
Yeah, but it's amazing. I mean, it's just very. Sometimes you have a stitch. It's the entry point of a bypass graft, which is fibrotic. All those factors can precipitate you not able to cross through. But here you can see its stitch is all going all the way down to the PT, so it was like
2-0.
most of a fem tibial
Compliant.
bypass.
And then get us a 1-0,
But,
1-0.
But it might be a
1-0
popliteal too,
Sapphire.
and that's where the
Looks
entry
like
of the
a popliteal,
bypass
yeah.
graft too. Yeah, so I think that's what the problem is.
Looks like I mean, if it's two bypasses, one of the bypasses definitely was to that spot. So
Some to the popliteal. Yeah, so I
almost
think
like
that's
it.
what's causing all the problems. But yeah, it's
So I think that what we need to do here is, I mean, we'll probably work for another 20 minutes, and then we're going to keep recording. I want to tell our crew that we want to record this whole case, and then we're going to just basically tell you what we did. We'll continue
Beginning of the
to
next session.
talk about it, and then we'll have it up on the website as to what we did. But I'm going to show you that we can cross. If we cannot cross, obviously, and then I'm going to take a picture. Sorry, you got it?
Yep.
yeah, I think
Real?
we
Real?
should be able to.
Real?
20 minutes we should be able to do this.
Yeah, yeah.
Real? Laura?
Stay still, my friend.
Okay, here we go.
All right, this is
So you
gonna
have
be
a
it.
you have a 2-0 compliant?
Yeah, 2.0 compliant.
Yeah,
We've got a
good idea.
guideliner there.
Guideliner.
I mean, hopefully it'll go.
Yeah, it's coming.
There it goes.
Nice.
All right, let's. I don't want to go too far. How about right there? Okay, let's go up here.
Yeah,
So
come up
this
to
is
the second
for,
stitch. Yeah.
for those of you guys who at home who don't know what a guideliner is. So obviously there's IR as well as in vascular surgery as well. This is basically an extension of your guide that'll come all the way down to the level of as far as you need to. We've had this all the way down in the ankle, me and Raman, depending on what are the things we've done, me and Vishal as well. And I think it just depends on where I'm positive. Down. So I think it depends on where you want to go. And I think another thing you need to do is, we learned this from Dr. Sharma, is go ahead and daughter it to see how it goes. If this 2.0 balloon goes well, then I think everything else will go. Give us a 4.0 now, guys.
Yeah, take the same coronary balloon you had
The
before.
floss test.
Correct.
Yeah.
The floss test. Exactly.
The 4.0, yeah.
Yeah.
One second. What is? There. So yeah, I think that's a very important point. What Atul just said, the floss test. And now we're just going to balloon with a 4.0, and then I'm going to take a picture, and then I guess we'll take a consensus with Karthik, Vishal, and Atul, because we don't have any data, and Raman, because we don't have data. Again, I don't want to be dogmatic. We don't have data in these long lesions. It's just our anecdotal, idea on what would work. So obviously, I think Dr. Guja's point of stenting it is probably the smartest here, because we're not going to get away without stenting. Sir, I know, but we're trying to save your leg. You just have to bear with us, please.
We're almost done, my friend.
Because I don't have much experience, and Vishal and Atul and Raman, I guess I don't have much experience in putting regular stents in the popliteal zone.
I have the water.
DES also. I've always put only.
So Karthik, explain to me. This is a great question, because you have used a lot of Supera. I know that. The question is, in this situation, when you have this vessel mismatch, Karthik, how do you deal with it at the level of here? You're going into almost, say, the distal pop, right, where it has tapered down quite a bit. How do you, so say we use this 4.0 balloon, and say this is kind of the balloon size we're going to use. How do you decide what is it called, the Supera, and how do you taper it, or how do you tailor it, I should say?
First of all, I don't think this vessel size is anything less than 5.5 at all.
Okay.
Because I mean, your 2.0 balloon looks minuscule. I mean, in this size,
Agreed.
I think 4.0 will look small too. But even if it's a smaller size, I in my experience with Supera, I have realized that 4.5 is not a good Supera to be placed at all. The restenosis, especially in this patient with protoplasm being bad and
Look
everything.
at that neck of the balloon.
Yeah. It's going to be very difficult to expand it. But even if it's let's say you put a 5.5, you technically 5.5 is creating a lumen of about 5.0 to 5.5. So even if your vessel is 5.0, 5.5 is actually a pretty good stent to put in. And it's very it's very unusual to see any popliteal less than 4.0. So even if it's a 4.0, 5.5 is still okay. You will have a little bit of, but radial strength of Supera is so good.
So how would you do it though?
So I would just balloon it. Balloon it with a 6.0 balloon. Create as much dissection plane as possible, and then put a Supera 5.5. Yeah, you will have a little bit of tapering. And if you're really concerned that your vessel is really smaller than 4.0, then I would put a DES, like a Megatron stent, like a 4.0 or a 3.5, and then taper it off with a 5.5 balloon until like it becomes 5.0, and then taper and put a Supera in a Megatron. Or a Megatron. Usually I put a Megatron in a Supera. I was going
to correct Karthik. So yeah, so what you'll do is, that would be what I would do is probably just use an aggressive balloon dilatation strategy. We're already subintimal, so we're not concerned maybe about how we're going to tear the vessel up or dissection. We've already decided on the stenting part. So you can use a 6.0 balloon to really dilate your popliteal. And then you see if you think it's less than a 5.0 vessel, I'd probably use a 5.0 Supera at least. Put it in, and then distally down, I would probably just cone it with a DES Megatron and expand it. Because remember what will happen is if you use a Megatron and put a Supera into it, it will definitely elongate. But if you do the other way around, the apposition and the Supera elongation doesn't happen.
Yeah, see?
Okay, very good. So we got flow down. So now let's go ahead. So now we're going to look above to see what we're dealing with, because this looks quite good actually.
Yeah.
As you
Again,
can see,
PK, there is, as you said, there is no particular data behind this or anything. And
Well,
again,
well,
it's just an experience thing. So
Karthik, I totally agree with you there. I mean, my point before was it's very important for us to be sort of state that, because I think that we have the privilege of teaching here and being online. I think it's important. We do a ton of cases. We have a lot of experience. But I think that's why I want to tell everybody, like, this is not an easy case. Like, Atul hit so many things on the head. You know, we've got this long lesion, we've got this dissected lesion, a fibrotic lesion, and we've got good vessel runoff. So how are we going to preserve this? So now I'm showing you this. And then what I want to do is I'm going to continue recording. I'm going to say goodbye to the audience maybe in 5 minutes, but maybe we can do something here. Would any of you do atherectomy here? Ah, my friend, you're not on a couch, my friend, please. I understand, but I understand you're in pain, but relax now, please. So what do you?
atherectomy here.
You would not do atherectomy. How about you? Anybody else?
No,
how about you guys?
I'll just balloon dilate it aggressively.
Would anybody use shockwave because of the level of calcium?
No.
Shockwave.
Not in this case. I mean,
assuming
you have that mid area, which was very bad. Remember that.
I know, but I'm assuming that this is all a dissection plane, PK. So that's
no,
why
I know, but
remember,
you're right. So. The shockwave is all about medial calcium.
I'm telling about this case, PK. I mean, if it was any other, this patient is not staying still. I would just balloon dilate it aggressively, finish the case as soon as possible, because he's just going to keep moving. With shockwave, he's going to have more pain.
No, but I think what we're concerned about is that area right there where the wire was pushed out. So I think maybe shockwave in that area. Sure. What do you think, Atul?
I mean, I don't think there's a downside in the sense shockwave is just a more aggressive balloon with the calcium. I don't think it'll have a greater advantage. I think you may get away with just ballooning, and if you can balloon and then shockwave, if you don't feel like you balloon.
All right,
yeah, I was going to say bailout.
All right. So give us a 5.0 long 018 balloon now, a 5.0 long 014 balloon. 5.0 long 014 balloon, and then an 018 Pacific Plus long balloon. Yeah. All right, I'm going to try that.
For this.
PK, why 5.0? Why not 6.0?
I just think that this area right here is not going to expand that well. I think we'll go 5 and 6. I don't think anything is wrong, but I'd like to balloon the pop with a 5 first.
Okay.
So down at the level of the pop, I don't want to put a 6 at this stage.
Yeah.
But I'm a little concerned, and Raman and I, when we crossed this, we both felt that it really pushed us to the side. So my question here is whether a shockwave here may not be a bad idea. But let's see. I agree with you guys. Let's take a look.
Yeah, I think it's a good shot. Go ahead.
So maybe you guys can talk about a little bit about what data is available in these long lesions. So this is a lesion greater than 25 centimeters, right? So let's talk a little bit about the data, because there's no head-to-head data. So we have the impact long, right?
Yep.
Impact long, which is 27 centimeter lesions, right. which obviously showed what is it called, a patency rate or a reduction in TLR at 1 year, but a 40% need for stenting. We need to change out this wire. Then you also have you also have the Zilver P. Go ahead, Michelle, while I work. I'm just going to go there now. No, you go ahead. Tell us. Go.
No, so Spartacore.
Yeah, and then also we have a data from Zeller, which is long SFA CTOs, which was more of an observational study, which also showed long-term patency being in the 80%. And then, like you talked about, the impact long data. Again, there's no head-to-head trials. It's all observational studies, of course, well conducted, like PK says, rigorous conduction. But from the data perspective, I really have to look up the exact numbers. Like I said, I don't want to quote anything wrong on the number part of it.
Yeah, you could just say the data that's available. I mean, with Zilver PTX, what Atul's point was, you had the Japanese PMA study. The Japanese PMA study had lesions greater than 300, 280 actually was the average lesion length, and they also had basically a primary patency rate at 1 year that was very acceptable. You're in the perineal. So you need to pull this back. That's all. There you go. That might be it.
Yeah.
Yep. Good. That's fine. Perineal's fine. Just walk it back now.
Yeah. So, 5.0 balloon.
There's a 5.0 balloon. I would go up a little bit. Yeah, I think that's a good spot, right?
Yeah.
So we're gonna go up here. So I think here, we do have some long lesion data, but let's not forget about Vibrant and Viastar. So I was gonna ask that question. Why not covered stents? You have 3 vessel runoff. Why not a covered stent?
No, that's a very good
point. It's not a bad idea.
Someone who failed 2 grafts on Eliquis, I think a covered stent is going to be a problem. I think in general, I think it's a great point, though. I mean, I agree with Karthik and PK. If it wasn't him with his history of failing 2 grafts on Eliquis, I think I'd be more inclined to say not a bad idea.
Yeah, it's a
I mean,
good
you should also
point
tell me
towards
what should you put them on after before maybe the rest of the audience leaves. I know Karthik is and I've become a big fan, Karthik, following your lead on, aspirin, Plavix, Xarelto 2.5 BID. But in this case, with A-fib, you're obviously going to put them on full dose anticoagulation.
Yes.
So you put them on dual gap as well. I would, for because bleeding risk is low. I
Leave it
probably
up
put
for a
on
little
gap for at least 2 to 3 months and watch them closely.
I mean, yeah, okay. I mean, I don't. Again, there is no data. I mean, if you extrapolate the coronary data, they say Plavix and Xarelto full dose is enough.
Right.
And that's what I do for peripherals also. I feel like triple therapy is
Killing
kind
too
of a
much.
stretch
Right.
for the patients, especially if you're using full dose of Xarelto. I just use Xarelto full dose or Eliquis full dose and just use Plavix. That's all I do now.
So
I
I'm
take off the
more, so
aspirin.
in general, but I'm maybe more specific to this case and kind of tailor the medicine to this patient who failed a graft on Eliquis and probably was on aspirin as well, if I'm not mistaken, from Twinkle's original presentation. He may not, but at this point, if you're going to put a DES in the, in a supera distally, then I'd probably go longer with the DAP with the Eliquis. But I guess like you said, it's all anecdotal. There's no proof to do that. But low bleed risk. And then I put 2 nicotine patches on them to make sure you stop smoking.
That's a great
one
point.
one on each leg.
I totally agree with you. No, I totally agree with you guys. That's amazing.
This
okay,
is an
go
area
ahead.
that we're also
As you can see, it's we know Elizabeth is fantastic. You guys have been with her for many years, and you've seen our live cases, and the patients are usually very well sedated. And you can see here, we're not doing an oversized balloon. We're not really in the subintimal plane as deep as Karthik and Vishal said, because of the fact that there wasn't much pain with the 4-0 balloon. So I think it's just a very difficult situation in terms of managing him and his medications, as well as his social habits is going to be an issue. So I think you're right. These points are very well taken. I don't know what I'm going to do. I think that Atul's point about the Viabon in a patient who's failed 2 grafts is worrisome, especially when you have to worry about this. But we do have 3 vessel runoff.
Yeah.
That is one positive, and we have not obstructed the distal collateral. So we could do a 5-0 long Viabon from below and overlap it with a 6, and then leave it be. But with heart failure, the issue is there going to be enough flow to keep this open? Because remember, you had a couple of admissions with hypotension, and that might have been part of the reason why his graft closed as well. So we have a lot of, this is kind of the way you want to think about a patient and kind of tailor the therapy to what the patient has. Sit down. Okay, we're going to take a shot now, Karthik, and then we'll decide on the 6-0.
Do you know if the grafts were fem tips or fem pops?
They were
because that makes a big difference, right?
They were fem below knee pops.
Okay, so that makes sense why they fail, right? I mean, fem below knee pops, patency, if I am not wrong, the numbers is 68%, right?
Yeah. Oh, yeah. Absolutely.
So that's probably one of the reasons also they kind of might have failed, right?
Well, yeah, of course, yeah. It's not a favorable.
Fem pops have a much higher patency rates than fem tips, so.
Yeah, it's not a favorable. How can you say an anatomic zone, Flora? Okay, we're gonna do a DSA here to see how it looks.
Yeah,
okay,
let's see how it looks,
lower.
and then we can determine the definitive.
Yeah, we just want to make sure. Look at this area. Okay, Cindy.
Nice.
It's fine.
That's a lot better.
Yeah.
So would you go with a 6 now?
Yeah, I would just go with the 6 and put a 5-5. I mean, if you guys want to put a DES, but that's a different story. But
so what I'll do is a 6
of. Go ahead, Vishal.
6 of balloon, put a 5 of supera distally, and then a long supera or a DS.
Give us the 6 018 long balloon. Atul, anything different?
Fine, 5-5. Okay.
No, I think that's a great call. I think the way it looks now, I think you have a much better judgment call on what to do. I'm just worried about where you're going to land at supera in the pop. I think that's
6 018.
It's just if you aggressively dilate the 6-0 with a 6-0 and then deploy 5-5, I think it should deploy at its optimal length. But again, you're right. There might be a little bit of elongation.
Until what I have observed with superas over time, I mean, again, there is no data about this or anything. But what I have observed over time is no matter how well you deploy the supera, in cases like this fibrotic lesions, if you put a 5-5, you're creating a lumen of 4-5. If you put a 5-0, you're creating 4-5.
So I want to just say one thing and compliment Raman and Sriya, our old fellow. So Raman and Sriya went over our database. We're about to send it in for review, and I can't talk about what we found. But interestingly, we looked at all of our cases done by us during their fellowship, And what we found was that we used DCB in Supera that was mal-deployed. And we have very good, interesting data. And these guys, I mean, I got to compliment both of them. They did an exhaustive angiographic review with Arthur Tarracone, who was also our statistician guy with that, and also with Farhan Serdar. So it was amazing. So the data is very interesting. We are going to send it in now. So that may actually influence how we treat this, hopefully in the future. I know we have to look at it. It may influence this, how we treat this in the future. So Raman is doing the right thing here, guys, for everybody at home. He's looking at where we can land the stent. I think we need to go a little bit further, huh? Yeah. So we're just going to lower, not the stent, the balloon, probably there.
Yeah, that's more than
enough. Yeah, I think we're going to just kind of dilate it like Dr. Gu just said, and then we're going to take it from here. So this is a 60018 balloon, and then now we're going to dilate this. And then I guess in 5 minutes I'm going to say goodbye to everybody, and then once we decide what we're going to do, we'll either be a Zilver or a Supera, and then we'll be done. Maybe we'll have Raman deploy the Supera down below live, and then we'll move forward. Breathe out, keep going.
So Pika, let me ask you this: before you deploy the Supera, again, like we said, no data. Before you deploy the Supera, because Supera is a bare metal, would you layer it up with the drug-coated balloon first and then do a Supera? I know you're going to say there's no study.
No, but it's very interesting. So the drug-coated balloon that we looked at was basically post-Supera deployment, right?
Correct. Right.
So we looked at that. So we don't know whether pre-Supera deployment drug-coated balloon will work. Interestingly, all of us who participated in our trial now, where we actually, not our trial, our meta-analysis, which we've just submitted, which we presented at TCT, where we looked at the modes of failure of drug-coated balloon.
Correct.
So I think vessel prep is very, very important, as we've learned in Supera, that the mode of failure in DCB is really 30% residual stenosis. Rutherford class has an independent predictive value, but lesion length and all these other things really don't, and calcification don't seem to play a role, nor does dissection grade. So clearly we looked at 600 patients in odd, over two randomized control trials and 3 very well done registries. So I think Karthik, and I know you've been stressing this, to be very aggressive with the POP. I think you're absolutely spot on there, because here, being aggressive with the POP is going to allow us to really expand our DCB, our lesion, our stent, whatever it may be, either Supera or not. So I think here we're going to do this. And Raman, you were going to make a point. I'm sorry to cut you off.
Yeah, I'm probably just going to say something just for the sake of a little bit of a differing opinion. I actually kind of like the idea of trying the DES, because we do have good data from the coronary field of these new stents that can expand up to even a 6.0.
Correct.
Low fracture rates, and especially in these highly tortuous proximal RCAs that we've been using them in. So it wouldn't be a wrong decision, I think, to try something a little bit outside the box here.
Sure.
Just considering about how unique of a situation this really is. And then as far as covered stenting, I think that will be a good option for when he comes back.
Not if.
Yeah.
When.
Yeah.
Raman's already saying to me we need to give the stage form. So we got to have that ready. Go up again. So so once we do this, we'll do a picture, guys, and then let's take a consensus vote, and we'll do what our consensus says, since we don't have head-to-head data. So Twinkle is going all the way up to 12 to 16 atmospheres on this proximal balloon here, trying to expand it. And I think both of you, I think all three of you were right on the money. Not to use shockwave, we save money, and I think we didn't need it in this case. Even more importantly. Interestingly, with the 6.0 Karthik, he did not have a lot of pain. So the question is this, or is that Elizabeth's sedation, or is it because we're not that subintimal or subadventitious?
Well, I'm sure it's the sedation. I think Liz probably didn't like him moving so much during the live case, so probably gave him a little bit, which is a good thing. I think pain during dilatation of the SFA CTOs, I don't think it's a good thing. It increases the inflammatory markers, but I think 5.5 Supera I would go with if I were you guys. And again, DES are not DCB are not before or after. I don't know if it makes any difference.
Right.
If you actually get a good luminal gain with a Supera, I think it's fine to directly just put in a Supera without a DCB also. So.
Okay, perfect.
Would anybody do a long DCB in the SFA and do spot stenting of the SFA if there's no, or you just do a full metal jacket?
Well, the problem, I think what we're talked about is exactly that, is that we don't know. We know that, at least from our data, at the impact ECB, residual greater than 30% is going to cause failure of the target lesion, right? So I think you may be right. I mean, I think this may be a good case for the TAC stent. So you don't put a full metal jacket, but I think it goes back to what Raman is saying, is that the patient is going to come back. So is it easier to treat a full metal jacket restenosis versus a thrombotic, Biobond graft, or an area with spot stents where you might get under the stent structure?
The answer is none. It's never been easier to treat.
All right, City. Exactly. So we're going to take a quick cine here, and then we'll just take a vote, and then we'll do this online but offline for everybody here. So we're not going to talk about this. So this is the distal. We got to stent that distal area. You can see that, right? So that, I agree with Karthik. Yeah. That looks like a 5.5 to me, man. I agree, Karthik. It's quite large. Let's go up now, Flora. So this will be a long.
You'll be landing the supera in P3 just above the bifurcation.
Yeah, but and then honestly, you can put a distal Megatron.
But that looks really big, though. I agree with Karthik. Yeah. That looks really big. I mean, I think we can get away. This has to be stented, obviously.
100%.
Yeah, this 100%. All has to be stented.
Yeah.
Right.
So this would be another 5.5. Yep. Well, which we anticipated.
Which is fine.
Yep. And then sitting here.
The only thing though is that focal segment that we've had so much difficulty crossing at the P3 segment. Yep. That still looks pretty bad.
Yeah. So we're gonna stent this up top with a Zilver. So we're gonna use 2 Superas and a Zilver. We're gonna do DCB the pop where the Supera is, and then we're gonna call it a day. So I just want to we'll continue recording with our AV team till we're done. Put up the full case in our website. I really want to thank all of you for tuning in. More importantly, Elizabeth for handling the sedation on this so elegantly, and also obviously Raman and Twinkle for the great presentation. She actually had a wonderful lytic presentation prepared, but this got carried away, and I know she's mad at me because she really wanted to present it. But what
next time.
Instant occlusion next time. And then,
exactly.
Save the lytic presentation for that.
So
for him to come back.
Yeah.
Wait for him to come back. That's a good point.
So for everybody at home, I just a final comment. I mean, you saw the difficulty in crossing these lesions. More importantly, you saw the wonderful differing of opinions, which I think is phenomenal, because you have 4 very experienced operators here. Excuse me, I should say 5, because even Raman, even though he's new, he's done a ton of cases. Very experienced, and you can see there's a lot of difference of opinion. And the whole idea is really try to elucidate the challenges that we face, but at the end is try to get the best result for the patient. So Karthik Bhai, I know you know I love you, and I'm sorry that if I was a little bit strong, but
okay.
but as you know, it's always meant in good teaching and trying to get the right point across.
Totally.
So with that, Vishal Bhai, we'll say why don't you sign off, and we'll continue recording.
Awesome. Thank you so much, everyone. Thank you for joining us.
PCB?
Great case by PK and Raman and the team. Thank you, Atul. Thank you, Karthik, again, for a good start to a new year. Wishing everybody another happy and safe 2022. Please be safe. Take care of you, your family. In the meantime, we'll continue recording. As like PK talked about, we'll be back next month for our February live broadcast, which will be February 23rd, 8 o'clock Eastern Standard Time from Mount Sinai, New York City. Till then, have a good day, week, and the rest of the month. Thank you.
So, Dr. Raman, can you tell me why you decided why you want to do that?
Really just like looking at this over and over again. I mean, again, just comes down to, I guess, there's different opinions. Remember that all of us work in the same institution, but we all of us have different anecdotal evidence as far as what is leaching, what is making us reach whatever conclusion we want. But just the way how the amount of challenge we had up front with getting even the teleport from the retrograde approach and getting our catheter across approximately even a 2.0 non-compliant balloon.
Right.
Being that we did get a 6.0 balloon to actually dilate that area, it's still the amount of recoil we're seeing even now is really significant. So my only concern is that if you put a Supera, the biggest predictor of failure is elongation, and I'm concerned that is nearly guaranteed to happen here. Versus with a Megatron, we can really prop it open.
So Raman, in your mind, I think I'm going to agree with what you're saying. I think you're absolutely right. Put a Megatron and then silver it all the way up.
Yeah.
Okay.
And then if he comes back, then we do the Viabonds all the way down.
So I think that's a reasonable idea. We're going to put a Megatron at the distal reconstitution zone, right at the level of that top collateral that comes off. And then we're going to go ahead and just Zilver PTXs. So Ray, we need a bunch of 60, 150, or 140 Zilvers.
Yeah.
And then we'll be done in a jiffy.
Yeah.
So is Damien getting the Megatron for us?
Yeah.
Wonderful. So what do you think, Twinkle? I mean, any
I
thoughts
agree with you.
on what? Well, I mean, you've obviously done a ton of these cases. I mean, I don't think you're wrong in doing a Supera in there. I think it'll be very challenging because I
Yeah.
think a 5.5 Supera is going to be, you're going to be dealing with a lot of the, what is it called, recoil that Raman is talking about, but a balloon expandable will allow it to stay open.
Right.
That's not really a crush zone. The crush zone is a little bit higher.
Yeah.
So I
that's
think
the
you're going to
thing.
be okay with the Megatron in that
Mhm.
spot.
Mm.
And I think putting a Zilver with a 1.8% fracture rate,
The other
Mhm.
side.
I think you're quite good with that as well.
Yeah.
So we're just going to
This-
get the Megatron together. Okay. Relax. We're almost done. 5 more minutes. Hang on.
Would you still have considered a filter here, given how long the
That-
lesion
that's,
was?
that's a
Which
really
one?
good. That's a really good point.
Mm.
I was kind of. I think we perhaps may have gotten a little bit lucky that our original estimation of the degree of thrombus and this atherosclerotic plaque was maybe a little bit more than what we had assumed here. But,
Right.
But a embolic event
Would have been catastrophic.
Exactly.
Yeah, but
and
you know, Raman, I gotta admit, you know, with what Vishal and Karthik was saying, the amount, the
Popliteal.
difficulty we had of
Popliteal.
crossing makes it difficult.
No,
You know,
distal
I think
pop-
thrombus would not
distal
be
popliteal.
much. Go ahead. Why don't you guys deploy the Megatron? I'll be right back.
1 second.
Megatron at its maximally rated burst can deploy up until a 5.57, 5.6.
575, yeah.
Yeah.
Even larger this one, I guess.
Yeah. So these can really get quite big. Let's get the get two of the long ones.
Yeah.
Is Luke in room 4?
Do you see
Luke?
it? It's the longest we had.
20.
I know.
is the longest.
We're almost done. No, I know you're doing a great job, Liz. It's a very challenging.
1 second. Hold on. You want us
Puff
DSA?
here. Just puff.
Is the long one?
Yeah, we don't have anything longer.
What number
Oh,
is
that's
this?
perfect.
5.
Okay, that's perfect. Maybe go forward a little bit, right?
Just a touch.
But why Megatron? We could have gone with the other one, right? The Synergy.
This
Hey,
one can
give
expand
us a
more.
little die, guys. I just want to make sure you hit that spot.
Yeah.
Oh yeah, perfect. Up, go up.
Going up.
So for everybody at home, we're putting the Megatron up. We didn't have a longer one, so balloon expandable stench is going to crank it all the way up to full, maybe to 18
18 or so,
atmospheres, and then down and go up again. And now get us a 6.0 Zilver, please. 6.0 long Zilver, bunch of them. Okay. We're almost done. Down. Good. We'll walk it out. 6.0 long Zilver. Let's open 2 or 3. 6.0 long, whatever the longest you got.
At this area where we had all the recoil, this is.
I'm just worried about Zilver in that area. We have the recoil, but if you're okay with it, I mean, do you want to put a Superi here and then a Zilver up top, or you think Zilver is fine because we expanded the 6.0 balloon?
Yeah, I think either one of those.
Like
would
I'll show you where I'm concerned. Scene minus.
Let's do a.
I think here you're good. I'm not worried about here. Yep, that's good. We gotta reballoon that with a 6. All right,
No,
6.0
stent is
140.
good. It's above. Yeah.
There's a lot of recoil still,
Yeah.
huh?
Everything proximal looks is really just. I mean, we could maybe just go from a 6 all the way up now.
Yeah, go with the
Yeah.
6.0.
Yeah.
Yeah. We have.
Which one are you opening?
Yep,
Yeah,
let's get the
perfect.
Zilver, and then we'll change this out for an 035 wire now.
If it's balloon, you want to balloon that or no?
No, we'll balloon it
This
at the end
goes-
with a large
goes
6.
straight.
Okay.
So this is important just to make sure that, this is still a freshly placed stent, so we still have to be careful as we're going into.
As
the
we're going into that
proximal
stand,
edge.
exactly. And that's why we're going to change out for an 035 wire.
Gently go in. That looks nice and gentle. Proximal edge
Okay.
looks good.
So Dr. Sharma, and then we're going to get this new supercore ready, or the old supercore, after we deploy this. Yeah, yeah.
Not that much
I like
overlap.
it. Yeah, I think you have to do that.
There it is.
Nice expansion.
There's
a balloon with a 6.0
yeah.
Dorado. All right, maybe a 7.0 Dorado. Who knows? All right, 035 wire now. Supercore. We'll take that out and just put this through. So yeah, so I mean, for the audience now what we're changing out an 035 wire as we do this. The 035 wire is going to allow us to give us more support to track a Dorado down, because now we've drugged the whole thing. So we're doing drug and scaffold because we really felt we're not going to be able to get a adequate patency without drug and scaffold. So now we're going to go and put this wire down, and Dr. Sharma is just going to walk it straight out. I'm just going to fix the sheath for him. That's good. Perfect. Now I'm just going to fix the sheath for him. And Dr. Singh is going to open the next 6.0 long Zilver PTX. So you're going to end up having 4 stents or so in this vessel. We are going to send it up to the osteum because I think no use of leaving any area where
which
we
one
think
is that?
It's gonna
140. Yeah.
6.0 140, please.
140. Yeah.
Dame, open 2 more, Flora. All right. Yeah, we're gonna at least 2 more.
Yeah.
Maybe 3.
Then a 7.0.
Yeah, we'll do 7.0 up top.
Right? Yeah.
Yeah, keep giving another 6, and then 2 more 6s, and the rest 7s.
Maybe if we are still live, maybe we could.
We are live.
Yes, maybe we could do Twinkle's lytic talk if you still have it up.
Yeah, actually, why don't we go with our slides with her talk, and let's give the talk now. That's a great idea while we work, and put us on the side while we're working.
Flushing it.
That's a great idea. So for those of you, obviously we were planning on lysing because we're worried about clot. There was no clot in this particular case. So Dr. Singh had prepared a nice lecture on lytics. So she's going to go ahead and give that quick talk while me and Dr. Sharma continue to stand.
Sure.
Okay.
Sure.
You're right, well expanded. Okay, one more.
3.
One more 6.0. 140. Okay. Go. We have another 140.
Oh, okay. All right. All right. So the talk today is about catheter-directed thrombolysis, essentially, which means direct delivery of thrombolytic agent into the thrombus, preferred for usually acute limb ischemia, DVT, AV graft occlusions. Altiplase, which is a recombinant tissue plasminogen activator, is the most commonly used agent today. So essentially, the recombinant TPA, it acts on the plasminogen, which is secreted by the liver, to converts it into plasmin, and the plasmin works on attaches to the fibrin clot and dissolves it into fibrin degradation products. Okay. So just to go over quickly about the absolute contraindications when a lytic shouldn't be used: active bleeding, GI bleed within 10 days, or CVA event within 6 months, intracranial or spinal surgery within 3 months, or head injury within 3 months. So the data that we have about catheter-directed thrombolysis, essentially 1990s 3 randomized trial. First one was Rochester trial, in which they randomized 114 patients, 57 patients to urokinase, and another 57 patients to immediate operation. Thrombolytic therapy resulted in dissolution of occluding thrombus in about 70% of patients. Cumulative limb salvage rate was similar in both the treatment groups, and cumulative survival rate was significantly improved in patients randomized to thrombolysis group, 84% in thrombolysis and 58% in operation, mostly attributed to the perioperative mortality in the hospital related to the surgery. Second randomized trial was called STYLE trial. 393 patients, they were randomly assigned to surgery or to thrombolysis with either recombinant TPA or urokinase. Patients were followed up to 6 months. And among patients with, the major finding of this trial was that the patients whose symptoms were longer than 14 days, the surgical group had lower amputation rates than the thrombolysis, 3% versus 12%. But in patients with shorter duration, less than 14 days symptoms, thrombolysis did better compared to the surgery, 11% versus 30% of lower amputation rate with thrombolysis. And the third randomized trial called TOPIS trial, thrombolysis over peripheral arterial surgery. 544 patients with less than 14 days were randomized to recombinant urokinase and primary operation. Their main finding was amputation-free survival rates at 6 months. They were not significantly different in either group. 1-year mortality or amputation-free survival rate also did not differ significantly in either group. So essentially all these three trials, they showed that they had comparable results between thrombolysis and peripheral arterial surgery, but in selected patients with lesser duration of symptoms, acute limb ischemia. Okay, so catheter-directed thrombolysis essentially can be achieved by either using our standard infusion catheters like Unifuse or Micromuy or Cragg-McNamara, or ultrasound enhanced thrombolysis catheters. ECOS is most commonly used, and the pharmacomechanical, essentially using a rheolytic thrombectomy along with thrombolysis in angiojet, or aspiration thrombectomy using penumbra along with thrombolysis. So just to quickly go over the infusion catheters that we commonly use in our lab. The first one is Unifuse by Angiodynamics. It's a 4 French and 5 French catheter. 035 are compatible with various shaft lengths from 45 to 135 centimeters, and their infusion length varying anywhere from 2 to 50 centimeters. So the basic design of the catheter is that the catheter has a multiple side holes, as you can see on the right side picture, and then there is a wire with a ball valve occlusion that occludes the distal part of the catheter, the end hole. And what it does is it essentially directs the TPA from the side holes and delivering the medicine right in the clot instead of delivering it distally into the vessels. So the another catheter is the Micromuy infusion catheter. It's a smaller 2.9 by Medtronic, 2.9 French catheter. It's an overnight wire compatible, shaft lengths of 150 and 180 centimeters, and infusion lengths of 5 and 10. The advantage of this is that it's flexible and trackable and can be navigated to distal segments in smaller vessels. It also has multiple side holes design and has platinum radio opaque markers, so for precise placement of the catheter proximal and distal to the thrombus. The third is by Medtronic is Cragg-McNamara valved infusion catheter. Essentially the same design, 4 and 5 French catheter, 035 and 038 wire compatible, varies shaft lengths from 40 to 135 and infusion lengths anywhere between 5 to 50. And you can either advance this catheter over the guide wire or use it even without the guide wire while infusing the TPA. Otherwise, by Medtronic itself is a ProStream infusion wire. It's just a wire with 035 and 038. It can be used with this McNamara catheter or by itself. It's a much smaller profile that can reach the distal vessels, and wire lengths available is 145 and 175, and infusion lengths of 6, 9, and 12 centimeters. Fountain infusion catheter by Merit Medical Systems is a smaller 4 French catheter with a shaft length of 90 and 135, and again varying infusion lengths. Same design as with multiple side holes that distribute the lytic agent throughout the thrombus. And also have a ball valve occlusion wire, as we discussed in our first catheter. Just to mention, a couple of the others are available. One is the ND Nabil Dib by Translational Research Institute, which is a 6 French catheter, much larger profile, but owen 4-wire compatible. And the other one is called TAPIS by Thermopeutics Inc. And it's a 7 French. Again, big catheters, so much bigger vessels, owen 4 compatible. So just to go quickly about the catheter-directed thrombolysis, the dose. So the most commonly is a continuous infusion, also called as low dose. So what we do is we do a 1 to 5 milligram bolus of the medicine, which is followed by a continuous infusion of 0.5 to 1 milligram an hour for anywhere between 18 to 24 hours and maximum up to 72 hours. Also, along with TPA, when the infusion is going on, we have to administer heparin through the proximal side port of the sheath at a fixed rate of 300 to 500 units per hour is recommended. Again, there is no standardized doses of TPA or heparin in these situations, but these were the doses used in most of the studies that have been done. So, in case there is no progress in recanalization of the lesion with the above mentioned dose, then it can be increased by 1 milligram an hour, and we have to perform a check angiogram the following day to see the progress of recanalization. The second regimen is high dose and also pulse spray regimen. It's essentially a 10 milligram of TPA dissolved in a 50 cc's of saline, essentially making like a lytic bag, and it's infused over 5 minutes in the thrombus. So either we can do that and then leave a continuous infusion after giving the bolus at a much lower dose of 0.04 mg per kg per hour, or we can just leave the above mentioned 10 milligram TPA in the thrombus for about 20 minutes and then take another shot and aspirate it. And just to mention that when we do these lytic catheters and leave the lytic medications, it should make sure that catheter is intraluminal, not in dissection planes. So after lytic therapy has been administered and the patient is on the drip, a couple of things about monitoring. Patient has to go to ICU. There should be hourly neurovascular checks with hourly Doppler and to see the progress, and labs every 4 to 6 hours. The most commonly the most important labs that we have to check is hemoglobin, fibrinogen, and APTT and FDPs. Most of the studies they say that if fibrinogen level drops less than 100 milligram, then the drip should be discontinued, or if the FDP value goes above 400, then the drip should be discontinued. Angiojet is one of the device that we have that can combine rheolytic thrombectomy and a power pulse spray, as I mentioned before. So it has both settings. It has a thrombectomy setting and a power pulse setting. So the first, it's primed in the thrombectomy mode, which is the regular mode that we use with normal saline. Then that lytic bag that we talked about, 10 milligram in 50 cc of normal saline is prepared. Then we have, and then the rheolytic thrombectomy catheter of the angiojet we advance it very slowly with 1 mm increments throughout the thrombose segment, with every increment giving a pulse. And then let it lyse the clot for like 20 to 30 minutes. And then we can use the aspiration to aspirate all that lysed clot. So ECOS is an ultrasound enhanced thrombolysis. It's a multi-side hole drug infusion catheter and has a multi-element ultrasound core wire. It's a 5.4 French catheter available in 106 and 135 centimeters, and a treatment zone varying anywhere between 6 to 50 centimeters. So the main design of the catheter is that the ultrasound waves, they loosen up the thrombus, in which case the TPA medication that is being delivered, it can deliver to a much larger surface area of the thrombus, and hopefully resulting in a much better result. That is it. Thank you so much. And
We're finished.
if
We're
you,
just closing
Aman, if
this.
you have
Yeah, of course. So
anything
we
to
just want to
add,
show you
and
what we feel is a great
yeah,
presentation, Twinkle. Thank you
Thank you,
again.
Twinkle.
So
yeah.
after a bunch of stents, we did the Megatron in the distal pop, followed by 3 6-Zilvers and then a 7-Zilver in the proximal segment, and these are our final results, followed by a 6 Dorado PTA
At high pressure.
at very high pressure, especially since the proximal segment was a little bit undersized, given our 7 stent, no perforation, nothing to really be concerned about, and all the way down into the trifurcation. The bifurcation looks very good.
Cleaning.
And for the sake
Cleaning,
of
Liz.
the patient, we're gonna begin to close. As long as we just
So
show
did you
this.
show the runoff?
Yeah, just working on that
Yep.
last one. Here we are.
Yep, so you can see the posterior tibial is patent, the AT is patent. It's just that the PT fills in all the way down. And we're not going to go after this AT because at this stage we've got the entire arch that's filling direct, and the patient is pretty much not cooperating at this stage. So I think we're going to be fine with this. So I've gone ahead, changed my gloves. Dr. Sharma is going to change his gloves. We're going to do a quick per close, and then we're done. So again, I thank all of you for staying with us, Twinkle. That was a phenomenal presentation.
Thank you.
Believe me, that was so important for everybody to understand TPA. So I think we will sign off here, and we'll see you all next week. So thank you again. I mean, next month. Thank you again.